Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Okay, let's unpack this. We're diving into a medical tool that's been the absolute standard for assessing traumatic brain injury, TBI, for, well, longer than most of you listening have probably been alive.
Yeah, that's right. We're talking about the Glasgow Coma Scale.
The Glasgow Coma Scale, yeah.
Yeah.
Introduced way back in 1974, just a simple measure.
And for decades, when someone had a traumatic brain injury, clinicians relied mainly on this single score, the Glasgow Coma Scale sum score. It was the primary way they'd classify the injury in those first crucial hours, the acute phase.
Yeah.
Mostly based on observing things like eye-opening, verbal responses, motor skills, that kind of thing.
And I get that it was groundbreaking back then, right? It gave everyone a standard language.
It did. It standardized how we talked about consciousness level, which was a big step.
But the problem, as I understand it, is you're taking this incredibly complex injury happening in the most complicated organ we have.
The brain, yeah.
And just boiling it down to three basic boxes: mild, moderate, or severe.
Precisely. And that simplification, well, it had some really profound real-world consequences for patients.
Consequences like what?
Well, think about the impact of just those labels. We heard from someone with lived experience who said that being diagnosed with a mild traumatic brain injury actually created huge challenges.
How so?
Because they constantly had to fight to get their symptoms, which were very real, taken seriously. That mild label worked against them.
Wow. So the label itself becomes a barrier.
It could, yeah. Another person shared that the label could sort of foster this passive, almost detrimental attitude, not just in care providers, but even in patients themselves, like a feeling of resignation.
And I suppose on the other end, calling an injury severe.
Right. That could sometimes lead to assumptions that there was just no hope for recovery, which might, influence decisions about care, about how aggressively to treat.
So these terms, mild, moderate, severe, they often just didn't capture the full picture of what was actually going on inside someone's head.
Exactly. They didn't reflect the true complexity, the extent of the structural damage, the physiological changes, and this created barriers. Barriers to getting the right care, the right follow-up, access to rehab.
Yeah.
Because people's needs just weren't fully understood from that one simple label.
So 50 years of trying to fit this huge spectrum of brain injury into just three categories, based mostly on one kind of limited clinical observation.
Pretty much, yeah.
But the big news now is that after half a century, this is finally changing.
It really is a significant evolution. A big international group came together, over 100 experts, researchers, clinicians.
And patients, too.
Yes, critically, people with lived experience of traumatic brain injury from 14 different countries. They've developed a new way, a much more comprehensive way to assess and characterize traumatic brain injury.
Okay, so that's our mission for this deep dive then. Let's unpack this new framework. We need to understand why it was so needed, how it actually works, and, what does this really mean for diagnosing and treating traumatic brain injury going forward? We've got some great source material to guide us here.
Sounds good.
So let's start by really digging into the limitations of that old way, the Glasgow Coma Scale. You said it's been the standard since '74. Remind us how it works and maybe where its biggest shortcomings were.
Okay, so at its core, the Glasgow Coma Scale is a clinical assessment. You observe the patient, their eye-opening, their verbal response, their motor response.
Right.
Each of those gets a score, a number, and you just add them up.
For that total score between 3 and 15.
Exactly, the sum score.
Mm.
And that sum score was then used to put patients into those broad categories. 13 to 15 was considered mild, 9 to 12 moderate, and 3 to 8 severe.
And the problem there is...
The fundamental issue is that you immediately lose so much crucial information. Traumatic brain injury isn't three neat boxes. It's a continuum, a spectrum of severity of injury type.
Right, it's not just black and white or even gray, it's shades.
That's a good analogy.
Yeah.
You lose all that nuance, that granularity. And beyond that, the old approach was largely, unimodal.
Unimodal.
Meaning it relied almost entirely on that single clinical assessment. It didn't really incorporate other incredibly valuable diagnostic tools that we now have.
Right.
Things like advanced imaging or biological markers we can measure in blood.
And I guess that lack of detail, that missing multimodal information must have had real consequences for care. And for research, too.
Absolutely. If you're lumping patients together who might have very different underlying injuries, different recovery potentials, just because they fall into the same broad category,
Yeah.
well, it makes it really hard to choose the best, most individualized treatments for them. And it also makes designing and interpreting clinical trials much tougher because your study groups might be way too varied.
And we keep coming back to this, but it seems so important, those labels themselves. Mild, moderate, severe. They carried so much weight, didn't they? Stigma, bias.
The sources really emphasize this. Patients labeled mild might have their persistent debilitating symptoms just dismissed, minimized, leading to delays in getting help or just feeling invalidated, which causes distress.
Yeah, I can see that.
And conversely, that severe label, it could sometimes, unfortunately, create this sense of hopelessness, maybe affecting really difficult decisions about medical interventions. These labels were meant for an acute snapshot, but they often got misinterpreted as these fixed long-term predictions.
So a system designed to help could actually become a barrier for some people. It really sounds like a complete rethink was overdue.
That's exactly the feeling behind this whole initiative. It wasn't just about the science. It was driven by a clear need for better, more patient-centered care.
Okay, so this clear need sparked action. How did this new framework actually get developed? Who was involved?
It was a major effort, launched back in 2022, spearheaded by the U.S. National Institutes of Health, specifically the National Institute of Neurological Disorders and Stroke, or NIH, NINDs.
Okay.
They really pushed for an international effort to create a new, more nuanced approach. Initially, the focus was on the acute phase, that first 24 hours after the injury.
And you mentioned it was international and collaborative, not just a few people in a room.
Oh, far from it. The sources describe it as this big international coalition. Over 100 experts from 14 countries, researchers, clinicians, but also, really importantly, implementation experts.
Yeah.
People who know how to actually get changes put into practice.
And people with lived experience.
Yes, absolutely crucial. People who actually live through different types of traumatic brain injury, different recovery paths. Their insights are vital.
Makes sense. How did they structure the work?
They set up 6 different working groups. Each tackled a key area: clinical assessment, blood tests for biological indicators, biomarkers, brain imaging, psychosocial, and environmental factors. They call these modifiers.
Modifiers, okay.
How to identify injuries, looking back in time, retrospectively, and, as I mentioned, that practical side, getting this knowledge into practice. They developed the framework through looking at all the existing literature, reaching expert consensus across different disciplines, and folding in those essential patient perspectives.
And even though the starting point is that acute first 24 hours phase, they recognize that TBI isn't static, right? It changes over time.
That's a really key point. They acknowledge that the injury and how we characterize it needs to be dynamic. It has to evolve as the patient's condition and recovery progress.
Which leads us nicely to the framework itself. It's called CBI-M.
That's right, CBI-M. And each letter stands for one of the 4 pillars of the framework.
Okay, break it down for us.
C is for clinical assessment. B is for biomarker, those biological indicators in the blood. I is for imaging, looking at the brain structure with scans. And M is for modifier, those other factors that influence things.
Clinical biomarker, imaging, modifier. So instead of just one score, we have these 4 dimensions shaping the picture.
Exactly. That's the core idea. Move away from the single number, the simple category. The CBI-M framework aims to combine information from all 4 pillars.
To do what?
To create a much more complete, a multidimensional picture of each individual patient's traumatic brain injury.
And the point of having that richer picture is?
The goal is to provide a characterization that's detailed enough to actually help guide individualized patient management decisions right from the get-go. And also to improve the scientific rigor of research by allowing for more precise grouping of patients in studies. It's about understanding the specific injury in the full context of the person who experienced it.
Okay, let's dive into each pillar then. Pillar 1, clinical. This sounds like where the Glasgow Coma Scale still fits in, but maybe differently.
Yes, exactly. The new framework still includes the Glasgow Coma Scale score itself, and also checking pupillary reactivity, how the pupils react to light. These are basic components because they are well-established indicators linked to severity and outcome. But, and this is important, it strongly emphasizes using the component parts of the Glasgow Coma Scale separately.
Meaning the eye, verbal, and motor scores individually.
Right. Looking at those individual scores actually gives you more detailed complementary information than just lumping them into the sum score.
So it's not just the total, but how the patient got that total that matters.
Precisely. And then they add other important clinical assessments as expanded components.
Like what?
Things like assessing post-traumatic amnesia,
Hmm.
how long after the injury the person was confused or couldn't make new memories. That's known to be a strong predictor of outcome.
Okay.
It also includes detailing specific symptoms, headache, dizziness, sensitivities to light or noise, ideally using standardized, validated scales designed for that, and crucially documenting anything that might be affecting the Glasgow Coma Scale assessment itself.
Like if the patient is intoxicated or
Sure.
sedated.
Exactly. Or intubated, or has significant eye swelling that prevents opening. All those need to be noted.
Right. So the clinical pillar really deepens what we look at compared to just the old GCS score. Okay, pillar 2, biomarker. You mentioned blood tests.
Yes, biomarkers are really exciting because they bring in objective biological evidence of actual tissue damage. That's a major step up from purely clinical observation.
What kind of biological indicators are we talking about here, especially in that first 24 hours?
For that acute assessment, within the first 24 hours, they recommend measuring one or more of 3 specific ones. Their names are a bit technical.
Let's hear them.
Okay. Glial fibrillary acidic protein, or GFA, ubiquitin C-terminal hydrolase, L1-UCH-L1, and S100 calcium binding protein B, S100B.
Okay, glial fibrillary acidic protein, GFAP, ubiquitin C-terminal hydrolase L1, UCH-L1, and S100 calcium binding protein B, S100B. And what do these tell doctors?
Well, these markers can actually pick up signs of microstructural damage in the brain, damage that might not even show up on a standard CT scan, a computed tomography scan.
So even if the scan looks normal, these could indicate something's wrong.
Potentially, yes. And what's really useful clinically is that low levels of some of these, especially GAP and UCH-L1, can very accurately tell you which patients have a really low risk of having a traumatic injury inside their skull that a CT scan would detect.
So if someone has a normal clinical exam and low levels of these biomarkers, they might be able to skip the CT scan altogether.
That's exactly the key practical application. 2 of them, GFAP and UCH-L1, are cleared by the FDA in the US, and all 3 have CE certification in Europe, specifically to help make that decision CT scan or no CT scan.
That seems huge.
It is. Some guidelines already using S100B have reported cutting down on CT scans by around 30%. That saves money, sure, but it also avoids unnecessary radiation exposure for patients.
That's a really tangible benefit. Are there things that influence these biomarker levels, though?
Yes, definitely. Factors like exactly when the blood sample is taken after the injury matters. The patient's age can affect levels too. And other injuries outside the brain can sometimes influence them, especially S100B. The sources also point out that the standards for using these tests, like reference ranges, cutoff values, are still being refined. Labs and testing methods need more standardization.
Okay, that makes sense. So clinical assessment, objective biomarkers from blood tests. Next up is imaging, pillar 3.
Right. Imaging uses scans to actually visualize structural damage in the brain. The main tool in the first 24 hours is usually the computed tomography, or CT, scan. It's fast, widely available.
What about MRI, magnetic resonance imaging?
MRI is generally more sensitive for picking up certain types of injury, but it's often less practical right in the acute emergency setting. It takes longer. Patients need to be stable. It is, however, used more often later on in the recovery process.
So what specific things are they looking for on these scans in the imaging pillar?
The basic components cover the common, really relevant findings. Things like, well, no abnormalities seen, different types of skull fractures, simple ones on the vault, depressed ones pushed inward, or fractures at the base of the skull called basilar fractures.
Okay.
Then the acute brain injuries themselves, bleeding outside the brain's tough covering, the dura, that's an epidural hematoma, bleeding under the dura, a subdural hematoma, bleeding into the space around the brain, traumatic subarachnoid hemorrhage, bruising within the brain tissue, a contusion, larger collection of blood within the brain tissue, and intracerebral hematoma, and bleeding into the brain's fluid-filled chambers, interventricular hemorrhage.
That's a much clearer way to think about it, different types of bleeding and bruising in specific locations.
Exactly. And they also include a newly refined term here, traumatic axonal and microvascular injury, or TMI.
TMI, what does that replace?
It sort of replaces older terms like traumatic axonal injury or diffuse axonal injury, because the thinking now is that, especially on acute CT scans, damage to the nerve fibers, the axons, and damage to tiny blood vessels often happen together and are really hard to tell apart visually. So TMI is seen as a more accurate description of that kind of widespread damage.
Traumatic axonal and microvascular injury. Got it. damage to nerve fibers and small blood vessels. Are there expanded findings in imaging too?
Yes. The expanded components add more detail, like the specific location of lesions, measuring their volume, especially if it's over 25 milliliters, which is quite significant. They also look for signs that the injury is causing pressure inside the skull, shifting things around, signs of mass effect or midline shift, any associated vascular problems, and also noting any pre-existing conditions or unrelated things seen on the scan.
Mm.
And they also mention the potential here for integrating these standardized imaging reports directly into electronic medical records, which could really help streamline things.
Okay. Clinical biomarker imaging. That seems to cover the injury itself quite well. So what does the fourth pillar, modifier, add to the picture?
Ah, the modifier pillar.
Mm.
This is where the framework really becomes, I think, multidimensional and truly patient-centered. It steps beyond the direct brain injury event itself.
How so?
It includes factors that significantly influence how a patient presents clinically, what their recovery path looks like, and their long-term outcome. But these factors aren't necessarily a direct measure of the acute brain damage. They're seen as modulators of the whole process.
So things about the person, their life, the circumstances around the injury.
Exactly. They group these into three broad classes: injury-related factors, patient-related factors, and community and society-related factors.
Okay, can you give us some examples from each? Injury-related first.
Sure. For injury-related factors, you'd consider how the injury happened, the mechanism, like a fall versus a car crash, any other injuries to the body. Secondary insults that might have happened after the initial injury, like low oxygen levels or low blood pressure, early seizures, even things like highly stressful circumstances around the injury itself, like if the person felt their life was threatened.
That makes sense, the whole context of the event. What about patient-related factors?
These are characteristics of the individual: their age, their sex, their past medical history, any medications they're on, like blood thinners, which are obviously important for bleeding risk, any pre-existing mental health conditions, their developmental history, any previous traumatic brain injuries, language barriers, general physical frailty, or issues with substance misuse.
So really factoring in the patient's overall health and background.
Okay.
And the last class, community and society-related factors. That sounds quite broad.
It is broad, and it acknowledges something really important. Factors outside the hospital walls have a huge impact on recovery. This includes things like social disadvantage or deprivation, healthcare insurance status, living situation. Do they live alone? Do they have family support? Financial worries, transportation problems, even food insecurity.
Wow, including things like social determinants of health right in the acute characterization. That feels like a really big, important step. Why are these seen as so critical?
The sources strongly emphasize that these modifier factors can have a profound impact on outcomes, even for patients who might initially look like they have a mild TBI based just on their Glasgow Coma Scale score.
How do they impact things?
Well, they influence everything from how symptoms are reported and experienced to whether someone can actually access rehabilitation services, the quality of that rehab, their long-term support network. It's all connected. Now, they do acknowledge it's challenging to assess all of these modifiers perfectly in the middle of an acute emergency.
Sure, that would be tough.
But recognizing their importance right from the start is critical for planning appropriate follow-up care and support.
This CBI-M framework really does seem to paint a much, much more complete picture than just that single GCS number. The case examples you mentioned really help illustrate this, right?
Absolutely. Let's look at case example 1. It describes a 28-year-old man who crashed his bicycle. His Glasgow Coma Scale score is 15, full marks.
Oh, okay, so under the old system, that's firmly mild TBI.
Right. He had a brief period of post-traumatic amnesia, couldn't remember things right after. His CT scan was normal, and he reported those typical symptoms: headache, dizziness, nausea.
So GCS 15, normal CT, probably would have been sent home with some basic advice in the past.
Very likely. But now, using the CBI-M framework, you gather more info. His basic clinical assessment is GCS 15. But the expanded clinical components note the post-traumatic amnesia and those ongoing symptoms. His imaging pillar is normal, yes. But his biomarker pillar revealed a high level of GFA, that glial fibrillary acidic protein, above the normal range.
Ah, so the blood test, the biomarker, showed objective evidence of some brain injury that the CT scan didn't pick up.
Exactly. And when you combine that objective biomarker finding with his persistent symptoms from the expanded clinical assessment, this whole multidimensional picture tells you that despite his initial GCS of 15, this patient actually needs follow-up, needs symptom-targeted treatment.
So the framework helps stop him falling through the cracks just because of that initial mild label.
Precisely. It prevents potential long-term issues from being overlooked.
That really highlights the value. What about case example 2?
Case 2 is a 48-year-old woman who fell at ground level. Her Glasgow Coma Scale score is 10.
Okay, so under the old system, that puts her in the moderate TBI category, already flagged as more serious.
Right. She also had lost consciousness at the scene. But again, the CBI-M framework gives a much richer, more detailed picture than just moderate. Her clinical assessment includes the GCS score of 10 and documents the loss of consciousness. The biomarker pillar shows a very high GFA level, 1,200 picograms per milliliter, way above the typical healthy adult range. Her imaging pillar isn't just abnormal, it shows specific findings on the CT scan, traumatic subarachnoid hemorrhage, and a contusion.
So you know the type of bleeding and bruising, not just that it's moderate.
Exactly. But then, crucially, you add the modifier pillar information for this patient.
What did that show?
Her profile includes some significant factors. She's unemployed, she has a history of a previous traumatic brain injury, and she also has a history of bipolar disorder.
Okay, those patient-related modifiers add really important context.
They absolutely do. And when you put it all together, the clinical findings, the very high biomarker level, the specific imaging abnormalities, and these modifiers, the multidimensional view from CBI-M, reveal something important. It reveals that this patient, because of the combination of intracranial abnormalities on her scan and these specific modifiers, is at high risk for persisting disability. This characterization goes way beyond just calling it moderate TBI.
And what does that mean for her care?
It immediately flags the need for really comprehensive follow-up care. Care that addresses not just the immediate brain injury, but also these other influencing factors. That means referrals to mental health support, maybe social services, care coordination, helping manage those modifiable risk factors that could lead to a poorer outcome.
These cases really drive home how this framework can create a much better roadmap for genuinely individualized care. It's based on a complete understanding of the injury and the person, not just that incomplete snapshot from the GCS.
That's exactly the goal, moving towards a more precise, actionable characterization for each patient.
Now, you mentioned this framework is initially focused on the acute phase, that first day. But TBI recovery isn't a quick fix, is it? It's dynamic.
Absolutely. And the experts involved are very clear about this. The way we characterize the injury needs to evolve as the patient recovers, over weeks, months, even years.
So what does that mean for the framework?
Well, while the initial framework is designed for that acute assessment, a lot more research is needed. We need to understand how the relative importance of the different pillars, clinical, biomarker, imaging, modifier, might shift over time.
How so?
For example, later on in the subacute or chronic phases, maybe detailed assessment of symptoms and functional abilities becomes the most important part of the clinical pillar. And maybe different biomarkers become more relevant than the ones used right at the beginning. That all needs further study.
And what about people who don't even go to the hospital right away? Maybe they have a concussion, think it's minor, but then weeks later, they're still having problems. How do you use this framework then without that acute data?
That's a real practical challenge they discuss in the sources.
Yeah.
If you don't have that objective data from the acute phase, the initial GCS, the early biomarkers, the first CT scan, you have to rely much more on the patient's own report, or maybe reports from family or friends.
Okay.
They recommend using validated questionnaires and protocols specifically designed to capture a history of past traumatic brain injury as accurately as possible. But they also acknowledge that the quality of previous medical records can be variable, making it tricky to get the full picture retrospectively.
And actually implementing something this comprehensive, it sounds like a massive undertaking across different hospitals, different healthcare systems, maybe different countries even.
It absolutely is. And that Knowledge to Practice working group was focused on exactly these implementation challenges right from the start.
What kind of challenges?
Oh, fundamental things. Just raising awareness about this new framework among clinicians, policymakers, the public.
Yeah.
Developing effective training materials. Figuring out how to integrate this complex, multidimensional information into electronic medical records smoothly. And then there are the practicalities of cost and accessibility, especially for things like biomarker tests or advanced imaging, particularly in lower resource settings.
So it's a huge step forward conceptually, but putting it into practice everywhere is going to take time and effort.
Definitely.
Given all that, what are the really key limitations of this CBI-M framework right now? Where does it stand?
This is a critical point, and the sources are very explicit about it. The CBI-M framework is not presented as a finished product, not at all.
Okay.
It's currently being Piloted, tested, primarily for research purposes, mainly in that acute phase.
So doctors shouldn't be using this routinely in the emergency room just yet.
No, absolutely not. It needs extensive refinement. It needs rigorous validation in large, diverse patient groups across different settings before it can be considered ready for general clinical implementation.
That's really important for listeners to understand.
Yes, the sources state very clearly that at this stage, CBI-M should not override any current established clinical protocols or guidelines for managing traumatic brain injury. And importantly, it should not be used as a clinical tool to predict outcome on its own right now.
Okay, not a prognostic tool yet. Given it's still in development and validation, what are the main things researchers need to figure out next? What are the key areas for future research?
The expert panel identified several priorities. A big one is figuring out the relative importance or the weighting of the different pillars and their components. Which pieces of information are actually the most crucial for understanding prognosis or guiding treatment in different situations.
Right. Does the biomarker matter more than the imaging in certain cases or vice versa?
Exactly. And how might that weighting change for different age groups, kids versus older adults? How does a framework need adapting for those later subacute and chronic phases of recovery? They also need to refine how the modifiers are assessed, especially making sure assessment is fair and relevant across different populations and cultures.
What else?
Standardizing those biomarker tests across different labs is crucial for consistency. Developing even better imaging tools, maybe ones that can see TMI more clearly, and of course, rigorously studying the best strategies for actually implementing this framework effectively and equitably across diverse healthcare settings.
So it sounds like a clear path has been charted, but there's still a lot of essential groundwork needed before CBI-M becomes the standard of care everywhere.
Precisely. It's a really important foundational step, a major conceptual shift.
Yeah.
But the detailed work of testing, refining, and validating it for widespread clinical use is very much ongoing.
Okay, let's try and bring this all together then. We started this deep dive by talking about that 50-year reliance on the Glasgow Coma Scale sum score, a simple number used to categorize complex traumatic brain injuries.
And how that simplicity, while useful initially, often led to problems, symptoms being overlooked, patients feeling invalidated, or prognosis being unfairly judged based on potentially misleading labels like mild or severe.
Right. And now we've explored this major international effort that's produced the Clinical Biomarker Imaging and Modifier, or CBI-M, framework.
A truly multidimensional approach. It aims to build a much richer, more complete picture by systematically combining clinical signs, objective biological data from blood tests, detailed structural information from brain imaging, and those crucial patient and societal factors, the modifiers that shape recovery.
And the whole point of this shift is to get a far more accurate, nuanced understanding of each individual's specific traumatic brain injury, moving beyond those potentially limiting labels.
With the ultimate goal being to enable more tailored, more effective treatment and follow-up care, right from those critical first hours and continuing throughout the entire recovery journey.
It's clearly still a framework that's being researched and validated, not quite ready for prime time everywhere yet, but it represents a really significant leap forward in how we think about, characterize, and hopefully manage these incredibly complex injuries.
It really does, a conceptual leap aiming for better patient outcomes.
So maybe a final thought for you to consider. Think about how this new framework, by deliberately looking beyond just those initial clinical signs, by bringing in objective data like biomarkers and imaging, and by integrating the person's whole context through modifiers, could fundamentally change things. Not just how brain injuries are treated in the ER, but how we understand and support recovery for months, even years afterwards. And maybe ask yourself, what other complex health conditions out there might benefit from a similar, comprehensive, multidimensional approach? One that looks at the whole person, their biology, their environment, not just the most obvious presenting symptom.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.